So my name is Darren Yuen. I'm one of the nephrologists here at St. Michael's Hospital. So I'm a transplant nephrologist by training, so I see people when you have a transplant, but I also see dialysis patients in workup for transplant. If you are in workup for transplant or hoping to get a transplant, you might see me or one of my colleagues, Dr. Zaltzman and Dr. Prasad. And so I thought maybe what might be useful for us to talk about is how we as kidney doctors assess kidneys when you are cleared for transplant. Like, how do we decide what kidney you get? And to explain a little bit about why it takes such a long time, why there's such a long wait time to get a kidney transplant. And then some of the challenges that we still face once you get to the front of the line and you're waiting to get a kidney, about how we even assess whether or not a kidney should be, this one should go to you. So please feel free to stop me if you have any questions. Try to make this as interactive as possible. Okay. So I thought I would just start off by showing two examples. These are artificial people. I've taken the pictures off of the internet, so these are not patients that are actually here at St. Mike's. So one guy on the left I'll call Bob, and one lady on the right I'll call Mary. And they're very different situations. Both of them are on dialysis, but Bob is 7 years old. He's a grandfather, has 4 grandkids, and has to do dialysis. And as you know very well, dialysis has a major impact on people's lives. He can't go visit his grandkids that are living in Florida because he has to be hooked up to dialysis. It's a lot harder to travel, of course, when you're on dialysis. On the other hand, you have Mary on the right, who's 20 years old. She has trouble finding work because of the same issues of being hooked up to the dialysis machine 3 times a week. And so this is a really big impact on her life in a very different way, but really clearly important. And so these are the types of people that we would see in workup for potential transplant. Oh, okay, yes. Okay, so how would we look at how we would get Bob or Mary a kidney? So the first step is blood group type. So you'll find one of the first things we ask or test is, what is your blood group? And there are 3 blood groups. There's A, well, there's actually 4, I didn't include that one, but A, B, and O, and then there's AB. AB is very rare. And that's important because we have to match the kidney, donor kidney blood type to your recipient blood type, okay? So let's say Bob is blood group A. So Bob can receive a kidney from a donor who's also blood group A, so A to A, or could receive a kidney from a donor who is blood group O. O actually means nothing. O is like 0. And so we call those universal donors. They can be transplanted to everybody, as you'll see. So those are Bob's options. Get a donor from, sorry? Cannot get it from B, okay, because B is different from A. And so Bob would recognize the B kidney as being incompatible and would right away reject it. Okay, in general. There are exceptions to the rule, but in general that's the situation. And so those are really his options in general. There are, as I said, exceptions to the rule all the time.
So O can go anybody?
O can be donated to anybody. Yeah, but O cannot receive from everybody. So it's a universal donor, but not a universal acceptor. Okay? And it turns out, as I'll talk to you about later on, that there are not as many blood group A dialysis patients. This is the way it worked out. And so the list is shorter for blood group A than it is for the other 2 groups, and that directly affects how long the wait list is if you're blood group A, and therefore how long you would have to wait for. Big differences, and I'll talk to you about those numbers. So let's say Mary is blood group B, way more common blood group type. And so Mary can receive a kidney from a blood group B donor or blood group O, like we talked about before, because O is a universal donor. There's a lot more B patients, and there are not many B donor kidneys. Many reasons why that's the case, but there's not as many B donor kidneys, and there's a lot of B dialysis patients. So it means that the wait time and wait list is way, way longer. And again, I'll give you the numbers afterwards. Okay, and then let's say someone is O. So O is a great donor status, but if you are O as a recipient, as a dialysis patient, it's much harder because you cannot receive an A kidney, nor can you receive a B kidney. You only can accept from an O. Okay, so for that reason, the wait list is very long for O as well, and therefore the wait time is very long. So in Toronto, at St. Mike's and Toronto General Hospital, the wait times on average, there are many different factors that can affect things, but on average, the wait time is around 6 to 8 years. Okay, so huge wait time. And this, of course, is for a deceased donor kidney. This is not as if you have a family member or a friend who could give you a kidney. Totally different situation. I'm talking about the people who are waiting, who don't have a family member or a friend who can give them a kidney, and they're waiting for a kidney from someone who's unfortunately passed away. The wait time starts when you start dialysis. So if you started dialysis in 2015, but you just get onto the list today, you are backdated to the day that you start dialysis. So if anyone is in workup and it's taking a long time, as I appreciate it takes a long time when we ask for a lot of tests, the one saving grace is that you are not losing time, because once you get on the list, you will be backdated to the date that you start, but still, it's 6 to 8 years.
I have a question. If you want to put it a waiting list, you have to go first with dialysis.
You have to be on dialysis.
And
Yes.
then waiting.
Yeah, so the question is, do you have to be on dialysis to be on this wait list? Yes, you do. Because the definition of when you start waiting is the start date of dialysis. Another question that some people may ask is, if you had a transplant before and then you have a failed transplant, go back onto dialysis, your start time is not the first date of dialysis start, but the date that you restart dialysis after your transplant fails. Okay, just to make it fair for everybody. And I promised you I'd tell you the wait times for the blood group A, and so again, it's a lot of factors that will affect things, but blood group A is a lot shorter. It's half the time. On average, 3 to 4 years. It's still 3 to 4 years. This is a long time. You have a question? AB is much shorter, very rare to have a blood group AB, but if you're lucky enough to have a blood group AB, it's much shorter. It's probably in the order of 1 to 2 years, or maybe even shorter, given that our list is actually really short now. They can receive an A, they can receive a B, they can receive an AB, and they can receive an O. So they're like the universal acceptor. Yes, yes. So the question, sorry, this is being taped. So if you're AB, you can receive A, B, O, or AB. So you are the universal acceptor. So therefore the list is short. Yeah. So the question is, can AB donate? It can only be, you can only go to AB as well. Yeah. So, and also very uncommon. So you're going to ask a question?
If someone is AB positive, he or she can donate?
Yes.
Positive.
Exactly. So the question is, if you're AB as a donor, could you donate to an AB recipient? Yes, you could. Yeah. And I think there was another question over here.
Now, how you will put the waiting list? Just starting waiting list.
So the question is how
Like we're going to put on waiting list for the dialysis?
So I think the question is, when does the wait time start? Is that what you're asking?
How start at the waiting list for kidney transplant?
So how do you get onto the wait list?
Yeah.
Okay, so how you get onto the wait list is you need to be referred to the transplant program at St. Michael's or whatever program you'd be interested in getting transplanted at, and then there's a whole long list of investigations that need to be done. You need to see a number of physicians, the surgeons, the doctors who put you to sleep, the transplant nephrologist, someone like me, and we assess lots of different things to make sure it's safe for you to get a kidney transplant. And so that process can take quite a while, depending upon how long it takes to complete all the investigations and what we find. but it can be in the order of months or longer, depending upon what we find. But basically, all those tests need to be done. You need to see all those doctors, and then after all those things have been cleared, then we would tell you that you are on the list, and then you would be on the list, and you would wait this amount of time for a transplant. Yes?
My question is, what does list mean? And the reason I'm asking that is my workup was complete and the package was sent to the transplant team on August the 7th. But last night at dialysis, Dr. Aslahi said to me, you are not on the list.
Right.
So can you tell me what she meant by that?
So the question was, your workup was complete as of August the 7th, I think?
Yes.
And so you were asking, were you on the list? And Dr. Aslahi, your dialysis nephrologist, said you're not.
Right.
So there's a different, and I apologize, maybe I misunderstood, but there's a difference between completing the investigations and having all the investigations reviewed and cleared, right? So you can have a test to look at your heart, but if they found that the heart had a problem, that of course doesn't necessarily, just because you finished the test means that you've been cleared.
So what it means is you have the package, but you haven't assessed it yet.
Yes, I presume. So the question was that the package was sent on August the 7th. It means that it has not been fully reviewed, or that decision has not been communicated back to Dr. Aslahi, or that there was something that was found on the package that warranted further investigation, and that's being communicated back to Dr. Aslahi. So there are many possibilities, but the bottom line is that there's something that has to be decided upon still. Okay? Okay, so the most important thing to start off with step one is your blood group type. The second thing is, do you have antibodies against the donor? And by that I mean, think about vaccinations. When you were a kid, or even now when you get the flu vaccine every year, hopefully you do, you get the vaccine, and the whole idea here is you're being exposed to something, and that causes your body to develop an immune response to that thing. So if the flu shot, you're getting an immune response to the flu shot, and so you have antibodies to protect you against the flu. And our body has developed this amazing ability to respond to pretty much anything if you've seen it once before. It's like, I've seen you, now I know you, and now if you come back into this room, I'm going to make sure you leave this room, kind of thing. It's a very, very potent and powerful system, and we take advantage of this with our vaccinations. The problem is that the body will think that a donor kidney that we give to you, unless it's your identical twin, will be like a virus. It will think that it is not you, and it will try to tell that kidney to get out of the room, and that's rejection. Okay? And so every kidney is, from every donor is going to look a little bit different, but they share a few similarities. So my kidney might look a little like your kidney, which might look a little like your kidney. And those similarities are a problem because if you've received any other things from other people, like blood, if you get blood from somebody else, you've ever received a blood transfusion before, you have been exposed to molecules that might make you have an immune response to those molecules. And so if the blood in that bag looks like the donor kidney at all, your body will have developed an immune response to it and will therefore be primed to get rid of the kidney when it gets transplanted into you. So this is a problem in that the immune response is so good at recognizing people that even if it looks a little bit like the blood that we gave you 10, 15, 20 years ago, the immune response will remember. Okay? So that's why you'll see when we meet you, we ask you, have you ever had a blood transfusion before? How many blood transfusions have you had before? You can imagine every time you get a blood transfusion, it's coming from a different group of people, and so therefore you're getting exposed to different things, and the immune response is getting to see all these faces, and therefore is going to remember all of them. Okay? So blood transfusion is a big, big deal. If you've had a lot of blood transfusions, unfortunately, it makes it less likely for you to be able to find a match. So you remember I told you the average was 6 to 8 years for blood group B or O, or average 3 to 4 years, and I told you there's a lot of other factors. One of those is this. If you've received, I've seen people who've had 20 blood transfusions over the course of their life, it's going to be a lot more difficult for us to find a matching kidney. And so therefore, that person's wait time might be longer than 6 to 8 years if they're blood group B. The lower picture is a picture of a pregnant lady. So if for women, if you've been pregnant before, your child is a product of you and your partner. And so your partner is going to be different than you. And the baby is going to have half you and half your partner. And that other half, unfortunately, is also going to be recognized by the body's immune response. And so therefore, it will know and recognize what it saw in the baby. So if you've had one pregnancy, 2, 3, 4, again, it's just like having one transfusion, 2 transfusions, 3 transfusions. So it also is what we call a sensitizing event. Now, thankfully, it's not as sensitizing as blood, because in that bag of blood, it may be that 10 people gave blood to form that one bag of blood. So it's not as sensitizing, but it is a sensitizing event. So this is why we ask whether or not you've had pregnancies before, if you've had transfusions before. And these are things you cannot alter. These are part of your history, and that's just something that will happen. But it does change the numbers. This is why those are averages of 6 to 8 years and 3 to 4 years. Okay. So there are other factors that will influence things too. Like we talked about, if you have a heart problem, that's going to delay things because we have to fix your heart. And if we can do it, if you have other issues, then we have to fix those issues before we can actually go ahead with getting you on the list. But the end result is that it's a really, really long wait. We recognize this. This is a huge problem that everyone faces around the world, and there are people working around the clock to try to figure out answers. And one of the other talks I gave at one point was talking about stem cell treatments, and the short answer is there are no stem cell treatments that are available at this time. Probably there will be at some point, but nothing that I would say I would wait for a transplant, like hold off on a transplant because maybe there's a stem cell treatment. I would not do that. I don't think there is a stem cell treatment that is going to be happening in the next 10, 15 years. So please do not hold off. These are people that have told me that they're going to wait because they've read something in the paper. I would not do that. I don't think it's likely in the foreseeable future. So a long wait. But the problem is there's still one more step. Let's say Bob and Mary have waited, let's say 6 to 8 years if they're blood group B or O, and then they're at the front of the line. It's great. They're at the front of the line. We're about to give them a call, and I'm on call today for nephrology. Hopefully I will get a call for a kidney. But what we've learned as transplant nephrologists is that not all kidneys are the same. Some kidneys, like the one on the left, is red, and so I colored that they don't look different color, but they're yellow. And that's just to remind me to tell you that they're not all the same. They're not all the same quality kidneys, because these are people that have passed away for other reasons, and they may have their own problems from before. And we don't want to discard any kidney that could be transplanted because the wait time is so long. We want to give as many of you a kidney as possible, as soon as possible. But that means that not all kidneys that we transplant are going to be 100% perfect. Okay? And that's okay, because not everyone needs a kidney that is 100% perfect. So I would say the kidney on the left, the red one, let's say that's a perfectly healthy kidney. That's a really young person who's unfortunately been in a car accident, no problems whatsoever, maybe 18 years old. I call those the AAA kidneys. Like, if you meet me in the clinic, I'll call them AAA kidneys. These are like the best of the best kidneys that you could get. Okay? Fortunately, if you want to think of it from the donor side, or unfortunately from your side, it is a very uncommon event. Okay? Not many 18-year-olds get into car accidents, thankfully, and so therefore there are not many super healthy people that get kidneys. And so if we only transplanted those people, the wait times would be even longer. They'd be like 16 years. So we can't do that. So we recognized that a while ago, and so we started accepting what I call AA kidneys. These are still really good kidneys, but they're not AAA kidneys. These are people maybe that are a little older, that might have had some other problems, but the kidneys are really still quite good. Okay? So that's okay too, but ideally, you would think that for everybody, we want to keep the list as short as possible. Someone like Mary, who's 20 years old, we want to give her the kidney that's going to last the longest time, like 40, 50 years. because we want to keep her off of dialysis for her, and also because for everybody, because if she's not on the list is one person shorter, and so everybody moves up the line, right? So everyone benefits if Mary gets a kidney that lasts a long time. Meanwhile, Bob, it would be great if we gave him a kidney, a AAA kidney that is going to last 40, 50 years, but if he's 80, he does not need a kidney that's going to last 50 years. We'd love for everyone to live to 130, but it's very unlikely that an 80-year-old is going to live to 130. So why not give him the much more common kidney, the AA kidney, that might last 15 years, 10 years, even 8 years. It gets him off of dialysis, and he can then go visit his grandkids in Florida, right? And he waits a shorter period of time. So that's the ideal situation where we give Bob the AA kidney, Mary the AAA kidney, everyone wins. And all the people on the list behind them, because the list is 2 people shorter, and it's going to stay shorter because Bob and Mary will live the rest of their lives with a transplant kidney, won't have to go back on the dialysis. Okay, so now I'm going to talk to you a little bit about how we decide if a kidney is AAA or if it's AA, and why that system needs to be improved, and what is the kind of new, as I was asked what to talk about something that's new in transplant. So in general, the AAA kidneys are the type of people I talked to you about before, younger people, like the 18-year-old, who have normal blood pressure and they have a lower creatinine level, okay? They have good functioning kidneys. The older, the AA kidneys are people who are a little bit older and who have may have high blood pressure. They don't have to, but they may. And they may have a higher creatinine level. Not super high, but higher than the AAA kidneys. So don't worry, whenever we offer you a kidney, we are happy with the quality of the kidney. It's a good kidney, but there are variations of good. There's AAA, there's AA. Okay, like I said though, the system is not perfect, and that's the problem. Some AAA kidneys don't do well, and we don't, to be honest, completely understand, and some AA kidneys do better than the AAA ones, okay? So this basic classification that we have is not perfect. Sometimes the older kidneys do great, and sometimes the younger kidneys don't do great, or not as good as you would expect. And that's the problem. And this is the problem because we're faced with this situation where we want to do this proper matching, but sometimes we don't. And sometimes Mary gets the AA kidney, meaning that she's back onto dialysis in a much shorter time than she should be, back at the end of the line, lengthening the line for everybody else, okay? And so our goal is to make sure the line is as short as possible. Everyone gets a kidney that lasts as long as possible. What I like to say, the right kidney for the right patient. Okay, so in truth, nephrologists, not just me, I'd say everybody, we are not that good at deciding if a kidney is AAA or AA. We're pretty good, we're not perfect. And we want to be perfect because we want to minimize the wait time for everybody and give you guys kidneys that are going to last as long as possible. What does this mean? So as I was saying before, sometimes this is what happens. Mary gets a AA kidney and Bob gets a AAA kidney. That's great. But Bob has to wait forever for that AAA kidney. He has to wait 8 years. And he could have got a AA kidney in a much shorter period of time. And Mary gets this AA kidney here on the left, and she's on to dialysis back in a much shorter time than we would have hoped, that she would have hoped. She's back at the end of the line. The wait list is one person longer again. So I really think we need to do better. We shouldn't have this situation. So the thought is, can we actually improve how we assess donor kidneys? And this is where I'm going to tell you something that's a little bit new that we're doing. This is actually only being done at St. Michael's Hospital, so that's kind of exciting from St. Mike's perspective. So how do we figure out if a kidney really is AAA or AA? I like to think of this picture here. So on the left is a healthy kidney. This is actually, if you take a look at the kidney under the microscope, this is what you would see, and then maybe a scarred or a AA kidney would look like this. And I don't need to go into too much detail, but in general, the scar is blue. And if you think about the kidney as a filter, right, the blood is filtered in the kidney to produce urine. And the filter is basically these small little holes here. These little white circles are where the filtration occurs. They need to be nice and white and open for you to filter the blood, like this drain here. It's draining the water from the street into the sewers, and so, you know, gets rid of all the toxins that you don't want on the road in this case, but in the case of you, in your blood. So you can imagine if the kidneys are scarred and full of all this blue scar, all that drain is blocked. Okay, it's all clogged up with this scar. You cannot filter out all the stuff. It gets stuck here, and all the water builds up here. All the toxins build up in the blood. That's what's happening in people who have kidney failure. You are having your filter clogged. And that's really bad because it doesn't just affect how well your blood is filtering, but it also causes your kidney to get worse over time. So if you have scarring in your kidney now, it's going to cause more scarring in the future. This buildup of the clogging of the drain just makes the kidney even more scarred. It's like this never-ending loop that's just going to cause more and more scarring. So scarring is not just that causes bad function of the kidney, but actually causes the kidney to do worse in the long run. And this has been shown many, many times. So if we look at people's kidneys who are scarred, that's in the orange, and kidneys that are not scarred in the green, and this is time. As you go from left to right, you're getting more time. And survival is of the kidney, so if the kidney is still working. The people who have more scarred kidneys, they fail much more quickly. So this is really important. If we could know how much scarring was in the donor kidney, we really could tell you, is it a AAA kidney or a AA kidney? And this is how I think we could maybe match the kidneys properly for Bob and Mary. Okay, so, well, why don't we do it? Well, you could theoretically do it. You could assess kidney scarring by a biopsy. Some of you may have had a biopsy before. And so it's like sticking a needle into the kidney. That's great. You take a little piece of the kidney, you look at it under the microscope, like getting the pictures I showed you. So we don't do this in Canada at all. I think it's, well, not all at all. We basically, 99% of the time, we do not biopsy transplant kidneys when we're assessing them. And you say, well, Darren, you just told me that scarring is important. Why aren't you doing this in the assessment? And there are many important reasons. The first is that biopsy is potentially inaccurate. And why is that the case? We only measure a small part of the kidney, less than 1% of the kidney. Because you can imagine if I chopped up the entire kidney, I would know exactly what's happening in the kidney, but then you wouldn't have a kidney to transplant. So I have to take only a small little piece of the kidney, and that's a problem. And this is an example here. So here is part of the kidney, maybe 1/2 of the kidney. And remember, the blue is the scar, and red is normal. So if I happen to take a biopsy here, I don't see much blue here. I'd say it's no scarring. But in the same kidney, if I took a biopsy in another place, there's maybe 50% of this box is occupied by blue, it's by scar. It's the same kidney. So I like to equate this to back in 2016 in the American election. I'm not going to talk politics about who I supported, but you know, if you were to poll in New York City who was going to win the American election, I think people would have thought that Hillary Clinton would have won. But it doesn't matter what New York City thinks, it matters what the entire United States of America thought. And of course, Hillary Clinton was not elected, and Donald Trump was. It's the same idea. It's all about sampling, okay? So this is one reason why we don't do it, because we may get very false information if we biopsy here versus if we biopsy here. It's not just that it's inaccurate, but it's dangerous. So remember, you're putting a needle into a kidney. The kidney gets a lot of blood flow. So even if we biopsy a kidney when it's outside of somebody, there's not any bleeding that's occurring because it's not getting blood flow. But once we put it into you, there's a hole in the kidney, and there could be bleeding that will develop. So the last thing you want when you've just got a new transplant kidney is to have significant bleeding from that transplant kidney. Okay, so we could potentially do harm for a test that's not really going to provide us necessarily accurate information. So that's why we don't do it. Okay? But we all, I think, believe that if we could do it safely and look at the entire kidney, that would be really, really helpful. So we need new ways of measuring kidney scarring that don't damage the kidney like a biopsy does, that assess more of the kidney, So not just a little piece, but everything that's quick, doesn't delay things, and that's accurate. So that is the kind of holy grail for transplant. So we can make sure that we know what a AAA kidney really is and a AA kidney, so we can give Bob and Mary the right kidneys. Okay, so many of you people might have had or know people who have had imaging tests of your kidney, ultrasounds, CT scans, maybe even MRI. You could say, well, why don't we do that? That doesn't involve needles. You can take a look at the entire kidney. That's a good question. Why don't we do that? Ultrasound is really available all over the place. It's been around for at least 50 years. It's safe. There's no needles involved. There's no radiation in ultrasound. It's quick. And you can look at the entire kidney. It hits a lot of the boxes that I just told you about. And we use it all the time. Sometimes we look at it for blockage of urine. So if you can't get rid of the urine from your kidney, we can see that. We can look for kidney tumors. It's being used all the time. Probably there's been 10 ultrasounds of kidneys that are done today already in the hospital. So why don't we use it in the assessment of transplant kidneys? This is the reason. So this is what we see when we look at any transplant kidney, whether it be a AAA kidney or a AA kidney. And I'd ask you the question, can you tell the difference between these two kidneys? I know one of them is scarred and one of them is not, but on the ultrasound, at least to me, they look exactly the same. Okay? So for whatever reason, ultrasound is actually not really good at assessing scarring of kidneys, which is a real shame, because if we could know exactly which kidney to give to Bob and which one to Mary. And so the question is, can we figure out another way? And one of the beauties of a hospital like St. Michael's Hospital is that you've seen the big glass building that's just north of the hospital. That's a research institute. That's where I also work over there. And we have this bridge that connects the hospital and the research institute. So people like me who have this really important clinical problem they want to fix can go over to the research institute and talk to scientists who might have a solution. And it turns out that there was someone at St. Mike's who had a potential solution but didn't know the question that needed to be answered. And so we had a conversation, and it's turned out to be, I think, really interesting and something that might start for people who might get a transplant next year. Okay, so many of you might have used this machine on your finger to measure the oxygen level in your blood, right? Or maybe you didn't want it done, but someone put it on your finger. And you remember there's this little red light that's on your finger. And we use it to measure the amount of oxygen in your blood. And it's something that we've had for years and years and years. And it just basically takes advantage of the principle that that red light is absorbed by blood. And we know that oxygen, blood that has oxygen in it, this is hemoglobin, is the molecule in blood, versus blood that doesn't have oxygen in it, absorbs the red light differently. And so the machine that you put on your finger can just tell how much red light's being absorbed, and then can tell how much oxygen is in your blood based on that. Because it knows, based on that, how much blood carrying oxygen is there. That's a very simple principle that we've been using for many, many years. You can make it much more fancy, and this is the guy that I've been working with, Michael Kolios, who's a professor of physics who works across the street. And he has a technique that is just a very fancy version of this thing that we put on our finger. And I just showed you a picture of a mouse here. But the idea basically behind this oximeter, this blood thing that we do, is you shine a light into something, you take advantage of the fact that hemoglobin blood absorbs that light and gets hot, it warms up a bit, and it sends a signal. So if you were to do this by shining light into this mouse here, that with red light, and the hemoglobin, the blood would absorb it, the blood gets warmer. Of course, if you leave it on too long, you start to heat the blood up and it starts to cook, so you don't want to do that. But you do it really short. So you do a really short pulse. It heats up. When something heats up, it expands. And then when you shut off the light, it cools down and it shrinks. So it expands and then it shrinks. And that creates this little vibration. It expands and shrinks. It creates a vibration like a wave that you put in a pool of water. And ultrasound detects these vibrations. That's all ultrasound does. So if you were to combine light with ultrasound, you can actually see hemoglobin, blood, and how much oxygen is in the blood. And that's actually being used now for cancer. But the question was, could we use this to assess scar? It turns out that it's not just blood that absorbs light, also scar absorbs light. And as long as you know what light to use, you can actually start to actually directly see the scar. Okay, so how did we do this? So some science here for you. What we did is we took scar and we took blood and we mixed them together to make a blood mixed scar gel that's sitting in this dish here. And we can change the amount of scar tissue that's in that dish, and that's the amount here. So I can know that there's either 10% scar, 15%, 20%, 25%, and this is what the ultrasound measure is measuring here, and you can see it's almost perfect. When it's actually 10, that's what the ultrasound measure says is 10. If it's 15, it's almost 15, 20, it's almost 20. It's almost perfect. So this ultrasound technique, based on using light and ultrasound, can actually really accurately measure the amount of scar, at least in a dish. That's a dish. So what about in kidneys? So you can't do this in humans right away, so we've done it in mice. So we have mice that we can induce scarring in the kidney to mimic what happens in people with kidney disease, or healthy mice. And we found the same thing. So here is the red is the scar. So there's not much scar in this mouse. There's a lot of scar in this mouse. And this is the ultrasound image that we see. You can see a lot of white, which is the collagen, and not much white here. So again, when we measure with gold standard measures how much scar is present in the kidney, so you go from here to here, there's more scar. What we measure with the ultrasound is almost exactly perfectly related. So we can actually seem to directly measure the amount of scar that's in a mouse kidney. So that's better than a dish of scar. We can do it in a mouse kidney. You don't care about a mouse kidney. I would presume you care about the human kidney that we would give to you. And that's a problem because a mouse kidney is like this small, and a human kidney is the size of a fist. So a human kidney is way bigger. So like everything you can imagine, when I have, I brought this flashlight to show me. So if I try to shine a light through my hand, you're not going to see the light, hopefully, through my hand because it gets absorbed by my hand. And so the larger a tissue is, the less the light can get in. And so we can do it into a mouse kidney because it's really small, but a human kidney is a lot bigger. And therefore, we have problems getting light into the human kidney. So we cannot do this through the skin because the kidneys are located right in our back, behind the skin, behind the muscle, behind the fat. It's really deep in the body. So we cannot actually do it through the skin. We couldn't do it, for example, for you right now through the skin. We actually have to have the kidney like right there, visible to us. So that's a problem for doing it in us right now. But for transplant, it's perfect because when I take a kidney out of me and I put it into you, the kidney's sitting out, it sits in a bowl. And so we can actually put the light source right on the kidney and we can actually get the light in. We've been able to show that we can get it in. Well, I'll show you we can get it in and that we can actually use our ultrasound technique. So it just so happens that kidney transplantation is the perfect situation for us to be able to do this. So we can actually use it to assess a kidney to make sure it's AAA or AA and to figure out whether or not we should be giving this kidney to Mary or should we be giving it to Bob. That's the idea. So the question is how am I getting human kidneys to study these? So the first thing we did is to start off with pigs because pigs just happen to have kidneys around the size of humans. And then we went to the United States where people who would be normally giving a kidney for transplant, but they found out that the kidney is too damaged to be used, those kidneys can be used for research. So we actually shipped kidneys up from North Carolina. We had a kidney from Puerto Rico flown up to us because it could not be transplanted, and then we start using our technique on those. So just to show you what it looks like, this is a pig kidney, and there's our ultrasound probe right here. This is a standard ultrasound image that everyone can get, and this is what we see with our new technique. So we can actually measure scarring in human kidneys. Here is maybe what we would call a AAA kidney that does not have a lot of scar. The red is a scar. You remember with the ultrasound technique I show you here that you can't tell a difference versus one that's really scarred, you can see that there's a lot of scar here, but you can't see anything with the ultrasound. I forgot I was going to show you this demonstration. I boiled the eggs, so I got to show you because I spent time doing this. The idea that I wanted to show you is with ultrasound, the standard ultrasound, like I told you before, the kidneys look the same, and that's what I'd say. These two eggs look exactly the same, right? One I know is hard-boiled because I hard-boiled it last night, and one is raw. But when I look at them right now, I can't tell the difference between the two. I'm wondering if you could dim the lights, because hopefully this will work. It worked before. So the idea is we're going to shine light into the kidney, and then we'll be able to see inside the kidney. So when it's raw, hopefully this will work, you can see it lights up. We can actually see inside the kidney. And if it's a hard-boiled egg, hopefully hard-boiled enough, you cannot see inside as much. So it's basically using the concept of shining light into the kidney to illuminate what's happening inside the kidney. And so this is actually what we see. For the first time, we're not seeing these grainy gray images. We're actually seeing these colorized images where the orange and red is scar. So now we can actually see how much scarring is present. It's just like shining light into the egg. We can see what's happening inside, and now we know the kidney on the left is a AA kidney that has scarring, and the kidney on the right, sorry, on your left, is not scarred, and the kidney on the right is a little bit scarred. Okay, so that's really quite exciting from our perspective, because this is potentially answering the problem that we've had, which is that we cannot tell how much damage is in the kidney. Okay, so where are we going to go, and why am I telling you about this? Because if you are clear at the top of the list, we have now got money from the Canadian government to fund a first-in-the-world trial of this technique. This is only happening at St. Mike's, where we're going to be testing kidneys when they go into use. So let's say I give you a call. I have a kidney for you. We're going to ask you as well if you would be willing for us to do this ultrasound technique of the kidney. While you're being prepared for the surgery, the kidney's sitting in the operating room, and we will do the ultrasound of the kidney while you're waiting. It does not delay your transplant at all, because you're getting prepared for the kidney. Usually there's a few hours actually between the time that the kidney arrives at the hospital before you're actually ready to receive the kidney, and we would be imaging the kidney there, and we would see how much scar is present. And then at the very least, when we give you the kidney, we'll be able to tell you how much scarring was present and therefore what to expect. Now you can say that doesn't really answer the problem, because all you will tell me is what happened to me, and you're right, and that's why I put this here, because we're asking for more money from the St. Michael's Hospital Foundation to do what I think is the more important thing, which is to actually assess it in the donor. When we first get a call that a kidney is available, I want to know how much scarring is present in that donor. So to decide, should that kidney go to Mary or should it go to Bob? But the first thing we needed to do was to do it just to show that we could actually get it done, and that's the first stage, stage 1. That's happening starting actually probably late this year, or probably more likely early 2020. And hopefully the foundation is going to be able to support us, that we'll do the donor study in parallel, so that hopefully in 3 to 4 years' time, we'll be able to have an answer to show whether or not this technique can actually help us decide, is this a AAA kidney or a AA kidney, and should the kidney go to Mary or should it go to Bob? So the end result is I really hope that what we're going to be doing is when we offer you a kidney, that we'll be able to give you the right kidney. So that Bob gets a kidney that's going to be good for him, that is going to be the AA kidney, and that Mary gets the AAA kidney. Everyone gets a kidney as soon as possible, and a kidney that's going to last as long as possible, making that list shorter for everybody else. So this is not possible without a lot of different people, so I wanted to just let you know this man, Michael Kolios, who's the physics person. This is a student. Many of the surgeons have been involved, so these are the transplant surgeons that will be seeing you as part of your workup, and also who would do the actual surgery. So Dr. Orden is the one on the top left here, Dr. Farkas, and Dr. Pace. And there's also another Dr. Reynolds, who just started as well. He's a great surgeon as well. So that's the team of people that are going to be doing this. So I'm happy to answer any questions that you might have about it. But if you do get offered a kidney in 2020 or beyond, we will likely be approaching you about this to hopefully help the next generation of people that are going to be offered a transplant kidney. That's pretty much it. I knew I wasn't going to go too long. I didn't want to keep you too long as well. I'm happy to answer any questions about this or about the transplant workup process in general, if you do have any questions. No questions, I answered them all. Yes?
I was just wondering, I don't remember the names of the grandfather and the...
Bob and Mary, yeah.
Bob and Mary.
I made them up, yes.
So let's say you've got Mary there, and you've got the donor, and you do this photoacoustic method, and you discover, uh-oh, this isn't the AAA kidney we hoped for, so do you tell Mary to go home at this point and ask Bob to, hustle in real quick, or do you have them both there just in case it's
Right.
better for one or the other? Or?
So the question is, let's say we find out that this kidney is a AA kidney and we were having Mary as the top of the list. Would we not give the kidney to Mary and would we give it to Bob? At this point in time, no. So this is still just a proof of that question. So we still don't really know, and so we don't want to change things. We don't want to stop Mary from getting a kidney at this point in time. So as part of the study, we are still going to go ahead with the transplant. So if the decision is made that I called Mary in for the transplant, we're still going to go ahead with the transplant because we haven't really proven this is actually going to predict outcomes. So this is the point of the study. That hopefully, though, by 2022, when we finish the study and hopefully prove that it does predict outcomes, then we will actually do exactly that. Instead of actually calling Mary in, we would have a measure of how much is this a AAA kidney or AA kidney, and make the decision then, if it's a AA kidney, not to call Mary in, and then to call Bob. That would be the ultimate goal in my mind. But for the next few years while we're doing this study, it's just going to be the same thing that we're doing already. We're just going to be adding the ultrasound on. Importantly, though, just so you know that you can choose to be part of the study or not. So if you get called in for a transplant kidney and the transplant kidney is there, we approach you for this ultrasound, you don't have to actually go ahead. You can say, no, I don't want to do this. There's no harm done there. The important thing to remember, though, is it doesn't delay your kidney transplant. It doesn't affect the quality of the kidney. So there's really no concern, but of course, this is totally up to you. You can choose not to, and we would, of course, treat you the same as otherwise. Yeah.
Once again, why do you need the patient's, the recipient's consent for this if it isn't going to affect them anyway?
So the question is, why do we need the consent of the patient if it's not going to affect them anyways? Because it's still going to be, we're doing something as part of a research study to a kidney that's going to go into you. And so it's your right to really decide whether or not you want to be part of a research study in the first place. So yes, my feeling is it's not going to affect you, but if you don't want to be part of a research study, that's completely fine, and you have the right to say no. Basically, that's just in general from a research perspective. If I want to, let's say, look at your chart to see whether or not the blood pressure pill that you're on is protective or not, I don't really have the right to do so unless you give me the consent to look through your chart, because that's your own health and your own private health information. The same principle here, that we don't want to impose upon you if you don't want to be part of it. Yes?
I was going to throw it out. So how come if I'm A and another patient I know, my team or my group is A, and I've been on dialysis longer, but they get the transplant first? Why does that happen?
So I can't hear you so well. It's the fan here, I think.
I'm actually not a patient, but
Yes.
but this happens, and the patients ask us,
Yeah.
why did this happen? So if I've been on dialysis for 5 years, and Mary's been on dialysis for 2 years, and I've met Mary, and we've talked, and we're both A positive, let's say.
Right.
But she got a kidney before me. How does that happen? Like, what happens in that kidney decision making that she got it before me, even though I've been waiting longer than she has?
Yeah, so it's a great question, and thanks for bringing it up, because I did not cover that. So it's
'Cause it
very
has-
common.
It does happen.
Yeah.
And we then get asked, and we're like,
It's a very common question. So remember, step 1 is your blood group type. So it is like one of the most important things. So in the situation that Fatima asked, which is we're both blood group A, we both know each other, and I've been on dialysis longer than Mary, and then Mary gets a kidney first. Why does she get a kidney first? Well, that's true, that seems confusing, but remember, the blood group is the first step. And there are many other steps that will influence things, and one of the big ones, which is step 2, would be whether or not you've been exposed to other things. So let's say I've received 20 blood transfusions, and Mary has received none. So I'm just, unfortunately, more likely, my immune system is going to recognize a lot of other kidneys out there, and it's just the way it is, and so it's going to be harder for me to find a match. And so the reason why we wouldn't have offered me a kidney is because all the other kidneys that have come up, I would have reacted to. So I would not have wanted those kidneys because I would have rejected those kidneys. So wait time is one thing, blood group is another, but if the kidney is not going to be matched for you because of this issue, you don't want to be offered that kidney because you would have rejected it right away. Yeah, Fatima.
So to extend that statement, so if I rejected it, so let's say you did give me the kidney, but then I rejected it, that would make it more difficult again for me to get another kidney because of antibodies from that transplant?
Yes, so yeah, that's a great question. So the other question was, let's say you get a kidney transplant and then you reject the kidney, or the kidney fails for whatever reason, would it make it more difficult for you to get a kidney? And you're right, so I should have put that picture up there. So the common ones are blood transfusions and having pregnancies in the past. But there are more and more people who've had a kidney transplant and that have kidney transplant have failed, and that kidney was not yours when you got the kidney transplant. Your immune system will have recognized that the kidney is not yours, even despite the best efforts that we have to prevent it. And so it will also be what we call a sensitizing event. So yes, it will also reduce your chances of getting a kidney. So while we always say if you have had a kidney transplant, you can always get a second, totally true. But important thing to remember is it's going to be harder to find a match because you've been sensitized by the kidney. The other important point is you are that many years older, so things could have happened, and unfortunately as we get older, things can happen. Number 2, and number 3, other medical issues could have arisen at that time. And so just because you were cleared in 2006 when you got your kidney, and then you come back now in 2019, you're not the same person that you were in 2006. So it's by no means that we don't want to give you a kidney, but we want to give you a kidney safely. The last thing we want to do is give you a new kidney, go through a whole surgery, and then we cause a heart attack or something like that. So always, always, always we want to make sure that it's safe. Because what's the point of going through a big surgery like this if it's not going to do you good in the end?
Any other questions?
Hopefully you found this helpful. Again, I'm happy to answer questions afterwards if you didn't feel comfortable asking it out to everybody.
But still, the latex is matching. You have to take so many things, right? Like how your protein and potassium and everything is okay, right? When you get a transplant, you have to take so many blood tests, right?
So the question is, you're as part of the workup, there are a lot of tests to be done? Sorry, in the donor or the?
From a donor.
Yes.
They take so many.
Okay, so this is a great question. So I think what you're asking, and tell me if I'm wrong, is you're talking about living donor transplantation, which I apologize, did not cover because I wasn't sure how much time we would have. But so living donor transplantation is very different, and I'm happy to talk a little bit about that. So in this case, you're not talking about waiting for someone who's passed away, but you have, fortunately, a family member or friend who could give you a kidney. So totally separate from the recipient, the donor also has to be assessed, right? And yes, you're the donor. You would have to go through a lot of tests to make sure it's safe. Remember, now we have to think about, you have to be, as the donor, live with one kidney, and we want you to be healthy too, because we don't want you to suffer from giving this kidney to your family member or friend. So a lot of tests are done. One thing to see is, do you have diabetes? So the blood sugar test. Is your heart good enough to go through the surgery? Do you have any evidence of kidney disease yourself? Because if you have kidney disease yourself, first of all, we would not want to give a damaged kidney to somebody else. And secondly, you already have damaged kidneys. So if we were to take one of those kidneys out, we could greatly increase your risk of kidney failure. So the guiding principle that we have here is that we want to make sure the recipient does well after the surgery and that the donor does well after the surgery. And that's the reason for the test. While it might seem exhaustive and we're trying to put up barriers. We really aren't. We're just trying to make sure that it's safe for you to get a kidney and then for you to give a kidney. Yes?
Here, this is a real life situation. I'm A negative, my husband is O. Kevin gave us results for a cross match, and he said, it looks like the titers are within an acceptable range that could make live donation possible. So how does that work? Here's a case of possibly an A going to an O.
So sorry, I misunderstood. So you're the recipient, is it?
I'm
the donor. And you're A.
And I'm A negative, and he's O.
And he's O.
And they did a cross match, and
Okay.
he said, it
Okay.
looks like the titers are within an acceptable range that could make the live donation possible.
Okay. So I deliberately avoided the living donor situation, so I apologize. But like I was talking about the deceased donor. In the living donor situation, that's a different situation where the blood type thing. Okay, so this applies to the deceased donor waitlist. If you do not have a living donor, this is the scheme that applies. If you have a living donor, as I told you before, there are variations to this and complexities that have allowed us to cross the blood group problem. Okay, so in the example that you gave, so donor being A, recipient being O, normally you would not be able to do that because normally you would be only able to get O, right? And in this case, because we know who the donor is, we can prepare the recipient to receive an incompatible kidney. Okay? In the deceased donor situation, we don't know when the donor is going to be available until the donor is available, ready to be transplanted within 24 hours. So we cannot prepare the recipient to receive that incompatible kidney. However, in this situation, we know well in advance of the possibility of this transplantation, and so there are certain situations where we can prepare you, the recipient, for your donor A kidney. And what it is basically is we look at the antibodies, like I talked about before, and look at the level of the antibodies in the blood. If they're really, really high, we cannot prepare you properly. You will still likely have a rejection despite all of our preparations. On the other hand, if your antibodies against A are relatively low, then we can try to prepare you to be able to receive an incompatible A kidney. Okay? This applies not just for A to O, but B to O, those types of situations. We can do it, but we can only do it in the living donor situation because we know about it in advance and we can prepare the recipient in advance. Does that make sense? And so it all depends on, do we know in advance? So you have to know about the living donor, number one. And number two, the levels of the antibodies have to be low enough that we can actually get it to basically undetectable so that we can go ahead with the surgery. If it's super high, we've learned that we cannot get it down to a level that's safe. And that's what Kevin was telling you about. So Kevin is one of the transplant coordinators. And so he measured the level of the antibodies that presumably that you have against her kidney. And the levels are reasonable to try potentially preparing you to get the levels undetectable so that you can get this A kidney. Okay, so that's totally separate from this. This is specific only to the living donor situation. And we have had quite good experience with what we call ABO incompatible transplants, which is like this kind of situation where we normally wouldn't be able to do it, but we've learned that we can. I think we've done around 30 or so far, and we've had really good results. But we're very careful about who we pick because we want to make sure that we can get the levels to a point where you'll be able to safely receive the kidney. Maybe I'll just cover one other, oh, sorry, yes, go ahead.
You mentioned about the heart. If the person has a pacemaker, is still allowed to transplantation?
So the question is, if presume the recipient, you would get a kidney, right? If you're a recipient and you have a pacemaker, and could you still get a transplant?
Yes.
Yes, Yeah, the answer is that in itself is not a reason that you couldn't go ahead with the transplant. The question is why you had the pacemaker in the first place. Is the pacemaker working well? You know, do you have any other heart problems that are kind of occurring along with the problem that caused the pacemaker? So there are many other things that could prevent you from getting a transplant, but just being a pacemaker alone, that is not a contraindication. That's not a reason that you could not go ahead with a transplant. There were some questions of the living donor, so maybe I'll just talk one more thing, is that let's say you have this A to O kind of situation where you're incompatible. There are other options to consider. So I would encourage you that if you have a family member or friend who is not this proper pairing, it doesn't necessarily mean that you can't go ahead. There's this ABO incompatible route that we talked about, but even if Kevin had said that your blood levels against the A kidney were too high, that they could not go ahead with this, it's not necessarily the end of the road. We have these registries across the country where we will try to find a donor that could be matched to you, that would be O, and that you could give your A kidney to somebody else. And so there are these paired exchanges that allow people to donate their kidney to somebody else, but then their donor gives to them. So just because you don't have someone that is blood group compatible and you have, that's a potentially coming forward to be a living donor, it doesn't mean that you have to give up. There are lots of different things that we've evolved to try to get around that. Okay. Yes?
Yeah, I just removed kidney, and after the kidney, and then every time I have to blood transfusion, and twice, that will, my antibody will be higher.
So I think you had said that you've gotten 2 blood transfusions so far. Is that right?
Yeah, two.
And will that affect your ability to get a kidney transplant? Is that right?
Because not yet, I still waiting the outcome and then answer, and then I already on the top.
Of the list.
Yeah, on the list, and the kidneys, heart doctor say okay, and then I will go back to the list.
I see. Okay, so
Because I already, kidney transplant called me 3 times.
3 times. Okay. So the story is that you've been called 3 times for a kidney transplant, but it hasn't gone ahead, and you have some heart issue that you need to see the heart doctor for.
Yeah,
I
but
see.
I test everything, but just see the doctor for the result.
I see. So you need to see the heart doctor for the result.
But I just want to know my antibody will be high. My kidney, blood transfusion,
Your antibodies will always be a little bit higher if you have a blood transfusion. So
even 2 times.
yeah, I mean, even obviously the 4 would be worse than 2, but 2 is still 2, and so you have gotten blood from other people. So it's just like your immune system has seen a number of people, and so it is likely that it will have developed antibodies against those people. And so yes, you will be a little bit harder, but the fact that you've been called in 3 times already means that, like you say, you're near the top of the list. And so usually my experience has been if we've called you already, it means that you're going to be called within the next few months again.
Yeah, because that time is third time they find it out I have a kid. I have all these systems at big, and that's why they have to remove the kidney.
Mm.
That's why after the doctor pays and help me remove. And but in every time I remove the kidney and then I have to transfusion.
I see.
Already twice.
Twice, yeah. Yeah, unfortunately, you had to have the surgery done, but the blood transfusion you needed. We're always very careful about getting someone on the transplant wait list of blood transfusion for this exact reason, but if you need it, you need it. Thankfully, you've only gotten 2, but it does make it a little bit harder for you to get to a kidney. It's not impossible, but it's a little bit harder. Yeah. Yeah, Crystal. So-
She can get only 1 kidney, right? She already lost 2 kidneys, so she can get only 1 kidney.
So the question is, do we only give one kidney? It's true for everybody here at St. Michael's Hospital. We would only transplant one kidney. We wouldn't transplant two kidneys. Regardless if you've had a kidney removed or not, we would only transplant the one. Yeah. Sorry, Crystal, I think.
What puts you on hold? Sometimes you're listed and then you're put on hold. What types of things would put a person on hold on the transplant list?
So one of the question was, what are some examples of what put you on hold on the transplant list? So on hold means that we would not call you. You're not off the list, but you're on hold, so you're not active on the list, so you don't lose your spot on the list. So examples would be, one example that has happened recently is you get called in for a transplant, and then they find some cyst inside your own kidneys that would be concerning, that maybe they want to make sure that it's not a tumor. So you would be put on hold until that is sorted out, because we would not want to give a transplant to you if you've had a tumor. So we would have it sorted out first. Another example would be if you have just had a heart problem, heart attack or something like that. God forbid you have one, but if you do have one, again, we're not wanting to say you shouldn't get a kidney transplant, but right after you've had the heart attack, you should not get a transplant because you have a higher risk of problems at the time of surgery. Remember, our guiding principle is we want to give you a kidney, but we want to give it to you safely so that you end up better off as a result. So we put you on hold until you recover, and then we just get the reports, let's say from your heart doctor, that you're fine again, and then you would go ahead with the transplant. So pretty much anything that would affect your risk of a problem at the time of a surgery for a transplant would be a reason to put you on hold. And we would just want documentation that whatever that issue was has resolved, and then we just activate you back on the list. The only thing that I would just say is that I recognize that everyone lives busy lives. Sometimes people's hold time gets extended because they don't necessarily get the documentation that they're better. They might be feeling better, but we actually need to know from whoever it is that needs to clear you that it's safe, because we need to make sure that we have documentation that everything is fine, that you've been properly assessed. So if you have had something that's put you on hold, please just follow up with whoever needs to clear you, because the faster we get that, the faster we can activate you back onto the list. I think someone had a question in the back there, yeah.
Yeah, does the multiple blood transfusion has effect on living donor?
Sorry, I missed the most important part, the last part of the question.
Yeah, because emphasizing on multiple blood transfusion,
Yes.
does it have effect on living donor?
So does multiple blood transfusions affect your chance of getting a living donor transplant?
Yeah.
Yeah, it potentially could, because it's the same idea. If you've gotten blood transfusions from lots of different people, it could be that those different people might look a little like your donor's kidney. And so it increases the chance that you will have a potential reaction against your donor's kidneys. So yes, the answer is yes. Yes?
Even to the blood transfusion happens like 10 to 15 years ago.
So the question is, if you got a blood transfusion even 10, 15 years ago, does it still affect it?
Yeah.
Yes, the answer is yes. So the same idea that when we get vaccinated against polio or measles as a kid, we do that as a kid, and we expect that it lasts for our entire life, because we're taking advantage of the fact that the immune system, once it sees it, it never forgets. And that's good for us, because you only need to be vaccinated once against something, but the problem is it works against us when we're looking for a kidney. If you've got exposed once, your immune system has a great memory. It will remember forever. Yes?
Yeah. Do you have any information or history of kidney when you receive kidney from someone? How you see, or you just check the kidney is fine and healthy, you transplant or
So the question is, do we get information about the donor when we get offered the kidney?
Or kidney?
Yes, we get a fair amount of information. So we will know the age of the person. We will know what medical problems they would have. We would know what their kidney function is, to the extent that we can find that out. So you can imagine if someone is brain dead, they can obviously not tell us this. So we're relying on family or friends usually to give us the history, but we usually have a fairly detailed history. We will not share that information with you guys because of issues of confidentiality. But the important thing to know is that we have, we do our, as I told you, we're not great at it, but we do our best at making sure that if we have a kidney, it is always going to be a reasonable kidney. It's just the kidney, I would argue, we could be better at being able to match kidneys to people. But if we're going to accept a kidney and give you a call, it means that it's passed through a very stringent process to say that this kidney is a good kidney. It's at least a AA kidney. It's just that I wish that we could give a AA kidney to the people that are going to most benefit from it, and the AAA kidneys to the ones that are going to most benefit as well.
So that means you don't accept all kidneys, right? Because if there's a problem with it, after doing that really big sort of inspection,
Yes.
you often will have to give up on a kidney that's been offered.
Yeah, exactly. So the question was, do we accept all kidneys or do we not accept all kidneys? And we don't accept all kidneys. So there are many levels of testing. So the first thing that's going to be done is the doctors who are taking care of that person. They will, for sure, already screen the person and say whether or not this is even someone they would call about to Trillium. The second level is that Trillium does its own screening to make sure, would this be a likely kidney donor? And so they've already gone through multiple hoops before I would even get the call. And if I get the call, we still turn down a good proportion of kidneys for those reasons. Again, our guiding principle is we want to make sure we give you a good quality kidney. So we often turn those down. And actually to that point, and this is more of a public service announcement to let you know, so many of the time when we get a kidney offered from someone who's brain dead, you can imagine there are certain circumstances that are going to put people into the brain dead situation, or accidents, et cetera, et cetera. Oftentimes as well, drug use, IV drug use, high-risk activities that could increase the risk for infections are common in the brain dead population, okay? And of course, we would never want to give you a kidney from a donor who has a serious infection like HIV or like hepatitis. We would not want to give you those kidneys. And so part of this intensive screening process is to make sure that that risk of transmission is as low as possible. Even in a living donor situation, however much we like to know that the donor situation, we can never be absolutely sure that the living donor does not have an infection. In the brain dead donor situation, we have to be very, very careful because we can't ask the person themselves. So we've evolved really, 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 really sensitive tests to look for the infections that you would want us to look for. HIV, hepatitis, West Nile virus, all these viruses that we would not want to transmit to you, we screen for. Okay, so it's got to the point now where even if someone was found in an alley with a needle in their vein, so we knew that they were injecting drugs right then and there, the tests are so sensitive that if they are negative, it means that the risk of transmission is minimal. Okay? So we will still use those kidneys because we've learned from our experience that the transmission risk is very, very low. So there is something we call exceptional distribution. This is what Trillium calls it, that if there was a situation where they were involved in high-risk activities, we would do the tests. We would never offer you a kidney if those tests were positive. Okay? So if we're offering you a kidney, even if it was from someone who is an IV drug user, the risk of transmission is really low. Sometimes Trillium requires us to tell you if, let's say, in that situation, that there was high-risk behavior, we would tell you that there was some high-risk behavior. We may not go into all the details, and that's what we call exceptional distribution. We'll ask you to sign a consent form, because Trillium requires us to do this. But as a transplant nephrologist, I think all the nephrologists here feel very comfortable with offering you that kidney. If it was my brother, my sister, me, I would accept that kidney. I'd rather have you off the wait list. I'd rather have myself off the wait list rather than waiting for another kidney, because these tests are so sensitive for HIV and hepatitis that we are almost absolutely sure that we're not going to transmit it. So I tell you this because when we call you at 2 in the morning for a kidney and we're telling you all about this stuff, it might sound scary, but the idea is that we've got these tests in place to be able to make sure that HIV and hepatitis are not a concern. Yes?
Is there a difference between a brain dead or cardiac death in the kidneys?
Yes, so so the question is there a difference between different types of donors? And so I've been talking about brain dead donors because they're the easiest to understand. These are people who are essentially in a vegetative state that don't have functioning brains, and they're legally we define as dead. There are some people that have a lot of brain injury, and so they're almost brain dead, but they're not truly brain dead. And so from a legal perspective, they're not considered dead. And so therefore, we should not and cannot take their organs. For that situation, the government of Canada has created a policy where what we do is we withdraw life support for those people. So they have to have life support to keep them alive. We withdraw life support, and if they pass away within 2 hours, we know that the kidneys are still usable. And that we call cardiac death, which is what Crystal was talking about, or heart death, meaning that we withdrew life support and the heart actually stopped beating, and that would be another definition of death, and then it is legal to allow us to use those person's kidneys. So there are two types of donors that we will talk about, and it's relevant not really from a transplant perspective, but it may mean that you get called in for a transplant. We're all ready to go. You're ready to go for the transplant, but the donor doctors withdrew life support, and the donor did not pass away within 2 hours, and so therefore the kidney is not usable, and so unfortunately then you would go home because the kidney is not usable. You would not want us to give you that kidney because it would be damaged, and so you might be called in, and then you might have to go home. And those situations are fairly common because these cardiac death donors are becoming increasingly common. So they're actually probably a little bit more common now than the brain dead donor kidneys.